What is asthma?
An inflammation.
But what is it?
Oh, it's
Asthma is an inflammation from an allergen.
I like that. All right. So this is a massive inflammatory or hypersensitivity response due to an allergen. When an allergy comes into your body says, something is wrong. And then what chemical mediator comes out as well in an allergic response? Well, cytokines probably will, but histamine. What's histamine's keyword? It's a hole poker. So it pokes holes in all of the vessels, causing you to be more leaky, which is why when you have allergies, you got, yes, you're leaking from airway. Yes? Okay. There are three main pathological things that happen in asthma because you're breathing in an allergen. Your body says something is wrong and it's going to start swelling. Yes? Because once it realizes something is wrong. So patho process number 1, bronchoconstriction. Number 2, that will happen in anaphylaxis. So bronchoconstriction. What process did we just describe?
Inflammation.
Thank you. Airway inflammation. And then how do your airways protect themselves? Mucus production. And that's where our drugs come off of, is those 3 pathological processes. Okay? So that's why they're so important to note. Those are the same 3 pathological processes in COPD, but COPD is caused by smoking. And asthma is caused by an allergen or irritants. Okay? Are y'all with me? Okay. This is a chronic inflammatory disorder. Once you have asthma, they say you have it forever. Now, you can definitely help your symptoms, okay? But if you're just like a hypersensitivity person, then you're just a hypersensitivity person, okay? All right. So, sorry, we're even talking a lot today. Okay. If you, though, get your allergens under control, you could never see asthma symptoms again. Yes? That's why they say you outgrow it, right? It's like a childhood illness and you can outgrow it. Yeah? Okay. What are the main triggers? Is that not the best smelling candle on the planet? Yes. You're welcome to light it. There's some lighters down at the bottom. If, I got to call you Penny now. And the reason my daughter calls you Penny. Aww. And so when we were on the Zoom the other day, she would like peeked her head in and she was like, excuse me. Or maybe it wasn't the Zoom, maybe it was in here. Where's Penny? And I was like, oh, she's out of town. And so now that she calls me, I feel like I gotta call you. So I'm gonna try. It's just gonna take me some time. Okay, what are the biggest triggers of asthma? Dust.
Cold.
Okay, cold, pet dander, pollen, dust, cockroach poop is a big one, right? Pollution. So anything that is irritating the airways that your body does not care for. Are you with? Okay. Before puberty hits, which sex is asthma most common in? Boys. After puberty, it is girls. Which race does this most often happen in? African American. There are 2 different responses because remember, your body will form a massive inflammatory response and then it also has a delayed response. The immediate response is which hypersensitivity? Type? Immediate. 1. And then it's going to have a delayed response, which is type 4. Very good. Oh my God, we're going to run right through this. All right. So the early phase response is usually in the first 30 to 60 minutes after you get exposed, right? You go outside, it's a high pollen day, and you're like, yeah? Okay. What white blood cells are responsible for allergens? The main one for asthma. We got to fix it. You can't be terrible at it no more. Okay. Eosinophils, those are the main allergen white blood cells. Okay. And then we already said histamine. And then Raquel told us cytokines. What is cytokines' job? They sound the alarm to bring something out. And then we've got the late phase response, which hypersensitivity, no, help me out. Type 4 hypersensitivity response. I couldn't get it out. That happens 4 to 10 hours after the original breathing in pollen. Okay. And then eosinophils, cytokines, and then lymphocytes, remember, come out in that late phase response. Yes. There is an asthma triad. Okay. There's actually 2 different asthma triads. There's one asthma triad that has like the common allergen conditions that exist together. So what 3 allergic responses usually happen together? If you got one, you got all 3. Obviously asthma.
Yes.
Seasonal allergies. And then when you get an allergic response on your skin, what's that called?
Oh, no. Oh my gosh.
the name of the allergen, you probably have it. If you've got asthma, you probably have had a flare up at some point on your skin.
The patches.
Usually like in the inside here, on the back of the knees.
Oh man, I just
I just saw a commercial for that.
Oh.
what is it?
Starts in E.
Starts with an E?
Hmm? Y'all know what I'm talking about though, right?
I do.
Okay.
Yes.
I don't know what it's called. It's called patches.
No, I know it's the word.
It usually happens in kids because they have really bad allergies and they get red really bad, itchy. It is crusty. It's eczema. Thank you. Thank you. But actually, eczema is like a layman's terms. Okay. What is the actual name for eczema? What's the name for skin? Derm. What is the name for inflammation? Dermatitis. And there's a word before it that tells me, because you've got contact dermatitis, you've got allergic dermatitis that you just came in contact with like chemicals or something. So what is the word that we use to describe eczema? And it's the same word we use to describe any kind of condition where there's an allergic condition. Y'all may not know this. I don't know. It's not anaphylactic. It's called atopic. So anytime you hear atopic, that means, or they say the patient has atopy, that means an allergy. So it's atopic dermatitis is the actual name of eczema. Okay. And then there's another triad where these three things usually happen together in asthma patients as well. It's asthma, nasal polyps. So they get like inflammation, big giant lumps inside their nose. And then NSAIDs or aspirin hypersensitivity. Remember, none of our asthma patients can have NSAIDs.
Okay.
Oh, y'all don't know that yet.
No.
You're still in second semester. You will be tested on this in pharm, ATI, NCLEX, adult. It's everywhere. Okay. You cannot give NSAIDs to asthma patients for two reasons. Number one, NSAIDs cause fluid retention. And last I need is a bunch more fluid in lungs. Number two, NSAIDs, there's a 10% of people with asthma have a cross allergy, kind of like penicillin, cephalosporin, cross allergy to NSAIDs. Okay, so it's going to sound like they should get it, right? Because we know that asthma is an inflammatory condition. So they may say something like, your patient is diagnosed with an asthma exacerbation and has been admitted to the unit. Which of the following drugs, if on the MAR, would you question? And it would say like ibuprofen, 400 milligrams for a fever greater than 100.4. And you're like, well, yeah, they need it for fever. And then they also need it as an anti-inflammatory. Sounds nice. And they want you to be like, no, not today. Do we understand? Okay. All right. Complications that can happen from asthma. They can get remodeling of the lungs. What does that mean?
They're going to reconstruct itself.
Yes, and so they get fibrotic and they get kind of messed up, right? Just like chronic inflammation does. Chronically inflamed cells can cause fibrosis, right? They can get status asthmaticus. What is that?
We can control it for greater than 5 minutes.
It's not an amount of time, but if you're giving back-to-back nebulizers and you're not seeing any change, that's called status asthmaticus. Now, there's not a specific amount of time, but what they usually will say is if you've given back-to-back treatments every 20 minutes for an hour and you see no improvement, then we'll typically call them status asthmaticus. And we have some Hail Marys that we will throw at them that we'll talk about in a bit. Y'all know what a Hail Mary is, I'm assuming. Okay, cool. All right. Patients with asthma are going to be at higher risk of COPD because of the remodeling of the lungs. Yes? They're at high risk for pneumonia because they have lots of fluid in there. They're at high risk of atelectasis. What is atelectasis? It's where the bottom of the lungs, I know, stick together. And that's because when they have asthma, they can't take a deep breath and open. So it'll get stuck down at the bottom. Yes? All right. Give me some signs and symptoms of asthma. Wheezing. Y'all, there's like 500 of them. Okay. Cough, shortness of breath, dyspnea. When are the symptoms the worst? When are the symptoms the worst? At night. It's a nighttime cough. They get chest tightness, anxiety. And then when you can't breathe, you go into fight or flight. So you're going to have tachycardia and tachypnea, and you're going to feel super anxious, which makes everything worse. Yes? Okay. They may get hypoxia. They could start hyperventilating. They have a prolonged expiration. What does that mean?
They're breathing out for a long time.
Yeah, they're trying to, but they can't, so they, right? They have hyperinflation of the lungs because they're trying to pull in so hard. When they're trying to pull in so hard, what do you see on your patient? Huh?
No,
Retractions, right? And so you may see hyperinflation of the lungs, which can push down the diaphragm, and then it makes it harder for them to breathe, right? They may come in tripoding. It is important to note for this whole respiratory module, the higher up your patient is sitting, the more distress they're in. And then the backward goes the same too. The more distress the patient is in, the more you need to sit them upright, okay? Because you cannot breathe laying flat. It smushes down your lungs, right? You'll think about it. When you're going running, and you're like running and then you have to stop running, everybody goes like this. Naturally, we all go. Our body knows to do that because it pulls the lungs forward and allows for more.
So we need to lean them forward versus sitting them up, or we need to sit them up?
Well, sitting them up is fine. Like the more sitting up they are, that's good. But if they're to the point where they have to lean over, then they're in pretty severe respiratory distress. But we leave them in tripod because that's where they're most comfortable. It pulls open the lungs. Does that make sense?
Yes.
Okay.
Funny thing, when I was on visit training, they started doing one of the things.
No, he wanted to do it like this. Yes, I know. I know exactly what they do there. Because when you're leaning forward this way, it is pulling out the lungs, but they want you to go like this so that you're opening the chest cavity. Either way, it's whatever your body wants to do is fine. But I know what you're talking about because all coaches do that. I know he's not called a coach, but you know, the same thing. All right. Moving on. Red flags. These are highly, highly testable. Like they may give you 4 patients that have respiratory conditions and you have to point out the one that's doing real bad. Don't look at your papers. Okay, these are red flags. So y'all should already know them. Okay. Your patient is coming in an asthma exacerbation and they start getting very restless and anxious. Are you worried or not worried?
Worried.
Why? What's that the first signs of?
But they can't breathe.
Oh,
Restlessness and anxiety are the first signs and symptoms of hypoxia. Okay. So yes, that would be a really big deal. All right. Your patient comes in for asthma exacerbation and they have a respiratory rate of 40 and they're sweating. Big deal or no big deal? Diaphoresis is the biggest red flag in respiratory, other than, of course, pink frothy sputum. If you are working so hard to breathe that you are sweating, that is bad. Diaphoresis plus tachypnea, those two together mean your patient's about to code. They're going to go beep, like that. Okay? No, it's not Shine-Stokes. It's just increased respiratory rate. Shine-Stokes is an abnormal pattern. Like it's like...
Like they won't die.
So it's kind of all over the place. Okay. All right. If your asthma patient, you're trying to get a history and they cannot finish their sentence, that's a red flag. If I'm like, hey, Raquel, what brings you in today? And you're like, well, I was going for a run and I was trying to go sit down, so that's a red flag. And if they cannot or will not lie down, that's a red flag because they're like, no, I cannot breathe. Like you can ask somebody to lie down. They may say that's not preferable, but if they cannot do it, they're in massive respiratory distress. Do you understand? Yes. All right. If a patient comes in and says, oh my God, my asthma flared up this morning, I'm having a really hard time. So you're like, okay, so you go to auscultate and you don't hear any wheezing. That's very bad. We want our patients wheezing. What?
We want our patients wheezing.
If in any exam they give you a patient that seems too comfortable, okay, that is your patient that's going to die. Let me tell you what I mean. So they may say, hey, you have 4 patients that are admitted for asthma exacerbation. Here's the assessments on each one. Which one will you see first? Patient number 1 comes in an asthma exacerbation. SpO2 is 92% on 2 liters of oxygen, and they have audible wheezes. How do you feel? That's actually not horrible for an asthma exacerbation. Yeah. 92, not that bad. They're on a little bit of oxygen, yada, yada. Okay. Let's see. Patient number 2 comes in with the refusal to lie down. Respiratory rate is 28. SpO2 is 94% on room air. It's actually not that bad. Yeah. Okay. Patient number 3, you walk into the room and they are sleeping comfortably with the pulse ox on. Red flag, right? Yeah, you might want to go poke them and be like, hello, sir. If they can, nobody will pick that because it sounds like, oh, no, that's nice. No. If you've ever had an asthma exacerbation, you ain't sleeping unless you're going to see Jesus. Okay. So it is very important to note that those patients will not be comfortable. And if they try to say that they are too comfortable, then it's halfway dead. Understand? Okay. Status asthmaticus. All right. So when a patient comes in for asthma, what's the first thing we do? Sit them upright. What's the second thing we do? Auscultate their lungs. What's the third thing we do? You can do no SpO2. What's the fourth thing we do? Oxygen don't do nothing. A nebby. I like it that you said it like that. My fourth semester is called clinical cliny, and it's just like it makes me laugh every time. They're like, "Oh, I can't. I got cliny on Friday," and I'm just it's clinical. Oh my god, it's so funny. Anyway, okay, so I forgot what I was saying. I lost it. Nebulizer. Okay, bronchodilator for asthma. Oxygen will do us little to no good. How come?
Because I can't.
The airways are constricted. All you need to do is open their airways. Yeah. Okay. So if you are giving them back-to-back nebulizers, which what are you putting in the nebulizer?
Oh my gosh.
Yeah.
Sorry?
Pretty easy question,
Antihistamine?
y'all. In a nebulizer, do you know what a nebulizer is?
Yes.
Okay. Okay. So what are we trying to do? We're trying to bronchodilate. So what is your drug that's your bronchodilator? Starts with an A. Albuterol. Oh my God. We're going to work today. All right. So we're going to put albuterol in the nebulizer and we're going to give that every 20 minutes. Boom, 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 boom. Okay. If you are not seeing an improvement within an hour of back-to-back nebs, Q 20 minutes. And that is called status asthmaticus. Yeah, it's fine. It's fine. Status asthmaticus. Okay. Other symptoms that they're in status asthmaticus. Now, their oxygen levels obviously are going to be very low. That oxygen goes on a seesaw with CO2. So their oxygen is going to be low. Their CO2 is going to be, what's that called? High CO2. Hypercapnia. Which, yes, they probably are in respiratory acidosis at this point. Okay. You may also see pulsus paradoxus. Anybody know what that is? The name is not going to tell you nothing. It's not your pulse. No. I mean, yeah, not really. No. Okay, well, let me ask you this. What is a, like, do you know what paradoxical means?
Isn't it like the opposite effect?
It will be in drugs. Okay, let me just tell y'all because the name really doesn't help at all. Okay, so it's when you are breathing in and your blood pressure tanks. And then you breathe out and it comes back to normal. And then you breathe in, blood pressure tanks. And that's because your lungs are already so hyperinflated, right? That when you're breathing in, it puts pressure on the heart. And so your blood pressure is going to drop. And then when you breathe out, your lungs shrink back and the blood pressure fills again. Does that make sense?
Yeah.
Okay. And it is very common with status asthmaticus for them to be in sinus tach. What's sinus tach? Yo, sinus tachycardia. What is sinus tachycardia? Huh? A fast heart rate, but it still is a normal heart rate. It's still, I mean, it's, the number is high, but it still originates from the sinus node, right? Mm-hmm. So their pulse is probably going to be like 120 in status asthmaticus. You with me? Mm-hmm. Okay. So this is where you're going to start to experience some hate for me. So I want you to turn over your papers and you're going to have to learn the stepwise therapy. Don't know what stepwise therapy is. It's right here. Little steps. Okay. So what stepwise therapy is it is what providers use to treat patients with certain drugs. Stepwise therapy. This is called stepwise therapy. Okay. So every step builds on the step before it. So basically you're going to start them out on one drug. And if that doesn't work, then we add another drug. And if that doesn't work, then we add another drug. Okay. So that's where you'll see the steps 1, 2, 3, 4. Okay. You with me? Well, okay. Yeah, I don't want to be, but yes. Okay. All right. And I need to make sure that y'all know the basic drugs before we start that. So which drugs treat number 1 right here, bronchoconstriction? What would we give for bronchoconstriction? A bronchodilate. Y'all need to write a little cheat sheet because you're going to forget it. All right. So bronchodilators are called SABAs. What does SABA stand for? Short-acting beta agonist. Very good. And this would usually be just like an albuterol inhaler, like 4 puffs. That's a SABA. Okay. There are also LABAs. What do you think that is? Long-acting beta agonist. Okay. What treats number 2 pathoprocess airway inflammation? What treats that? How do we get rid of inflammation? It's an easy question. How do we decrease inflammation with the drug? God's sake. Yeah, what drug? Well, we can't give NSAIDs. Corticosteroids. And those end in Sone or Solone. Okay. But we're going to give that as a inhaled form of a steroid. So it's called an ICS, inhaled corticosteroid, ICS. Okay. Y'all with me? Yes, or prednisolone, or actually the most common one is called fluticasone.
Oh.
Okay. All right, so let's talk about stepwise therapy. So for each step, okay, we're going to characterize their asthma based on their symptoms. When do symptoms happen most for asthma patients? At night. And then every step, remember, we add to, we don't take away. Because the first step didn't work well enough, so we need to bump it up. You see what I mean? All right, so step 1. SX means symptoms, just in case you didn't know that. So symptoms less than 2 times a week, and they're totally fine between exacerbations. The exacerbations are really brief, and they're just kind of a variable intensity, meaning sometimes they're kind of bad and sometimes they're just fine. If that's how they describe their asthma, that is called mild intermittent asthma, which makes sense. Symptoms aren't that bad. They're not all the time, less than 2 times a week, right? And they're pretty mild when you see them, just kind of intermittently. Yeah. So for step 1, we're going to use a SABA PRN. So how would I explain that to the patient? Right. So if you feel cough, if you feel like you're wheezing, then you're going to do 4 puffs of an albuterol inhaler, okay, up to every 4 hours as needed. That's our step 1 therapy. And I'll say, hey, if it's getting worse or it's not getting any better, come back in. So the patient comes back in a month, okay, and they're like, yeah, I've been using that SABA as needed, but now my symptoms are happening more than 2 times a week, but not every day, and they're less than 1 time a day, right? If I move around a lot, like if I go running or something, I'm definitely going to start wheezing afterwards. Then I'm like, okay, you're not really very well maintained, are they? Okay, so I'm going to keep step 1 therapy, which was SABA PRN, and I'm going to add a low dose inhaled corticosteroid. That's what LDICS is. Okay. So, and the ICS you take every day, whether you feel good or you don't feel good. It's a maintenance medication. When do you take the SABA? So that's as needed. That's a rescue medicine. When you have symptoms, you rescue yourself. And ICS is meant to keep inflammation down over time, right? So that's called a maintenance medication. It's a maintenance med. Okay. All right. So the patient comes back in a month and they're like, man, things are going really bad. Springtime came. Okay. My symptoms are happening every day. I'm having to use my inhaler every single day. When I have an exacerbation, I can't even like go to a birthday party or whatever because I can't freaking breathe. I'm having them at least twice a week, and sometimes they last for 2 or 3 days. Does it sound like we're very well maintained? No. So we're going to keep with step 1, which is SABA PRN. We're going to add step 2, which is so the LDICS, and then we need to go to step 3. Instead of an LDICS, we're going to do an MDICS. What do you think that is? What was the LD? Low dose. So we're going to medium dose. Okay. So we're going to go to a medium dose. We're going to up your dose. Okay. She comes back in a couple days, and that's called moderate persistence. Y'all can see there's the name of the asthma, which stepwise therapy we're going to use. And then here it'll show you exactly what the characteristics are of that type of asthma. Okay. All right. So step 4. Okay. They say, hey, for the last 2 days, it's been just one big exacerbation. My symptoms are continual. I can barely do anything. And I'm just having these flare-ups all the time. That is called severe persistent, right? These are really bad symptoms and they're not letting up. Okay. Look at me, not your papers. So I need to keep with step 1, which is SABA PRN. Number 2, low dose inhaled corticosteroid. Number 3, medium dose, SABA plus medium dose inhaled corticosteroid. Which one of those is the maintenance med? Inhaled corticosteroid. Which one's a rescue? The SABA. All right. So in step 4, we're going to do the SABA PRN. We're going to go to high dose ICS. Okay. And now we're going to add a LABA. What do you think a LABA is? Long acting beta agonist. Okay. And then we may or may not need to add oral steroids at that time if they're in an acute exacerbation. I may give them like 3 days of prednisone. Do you understand? Okay. Do you understand what stepwise therapy is, how to name the type of asthma and the symptoms that go with it, and then how we give medications? All right. Oral steroids. We may need to give oral steroids. You could either do SABA PRN or a LABA. You can or you don't have to. Okay. All right. Do we understand the basics of asthma?
Oh yeah, that's the next page.
Look through it and just make sure. How do we diagnose the asthma? Same way we diagnose COPD.
Yes. We're gonna check the lungs.
Yep. How do you do that?
Pulmonary.
I need to see what their lungs are doing, right? Not a picture of them. You were about, what did you just say? No, you said something after that. She's like, well, I've been already forgot it. This is where you put them in the phone booth, the clear phone booth. You know what I'm talking about? Oh. Pulmonary function tests. You're going to do pulmonary function tests. There's this like see-through or clear phone booth thing that they go sit in. It's got a pipe on the floor and they're supposed to put their mouth on it. And like, they tell them like, hey, take deep breath and then let it out and blow it out and do this. And they are looking to see what your lung capacity looks like. Okie doke. Yeah. We may do RAS testing. Do you know what RAS testing is? Mm-hmm. That is the blood test that they do for different allergens because what causes asthma? Okay. Well, yeah, so I need to see what you're allergic to, right? Mm-hmm. All right, we will look at family history. Now, spirometry, there are some nursing schools that are still using that word for pulmonary function tests. So if you see spirometry and pulmonary function tests, it's basically the same. Now, I'll do a chest x-ray if they're in an acute exacerbation, right? And look at their SpO2. I'm also going to look at their IgE. What's an IgE?
Inflammation.
Immunoglobulin E. Yes, IgE comes out in a major allergic reaction. So I'm going to look and see if your IgE is elevated. I'm also going to do a CBC with diff and look at which white blood cells. Eosinophils. So you're looking at an IgE and there's eosinophils. Yes? All right. If the patient is really bad in like ICU, then I'll draw ABGs as well, right? All right. When a patient is in an acute exacerbation, so you're in the ER, the patient comes in, they're all, what's the first thing you're going to do?
Sit the patient up.
Sit the patient up, right. Then what?
Listen to the lungs.
Okay. Auscultate, put on a pulse ox.
Yes.
Pop them on a nebulizer. What's in the nebulizer? Albuterol. And we're also, when they're in acute exacerbation, we add ipratropium. Anytime something ends in tropium, it is, number one, an anticholinergic. What's your keyword for anticholinergic? Drying. I'm going to kind of dry out some of that mucus. I don't want to completely dry them out, but they're drowning, okay? And ipratropium is also a bronchodilator. So you're going to give both of those together in the nebulizer. You're going to do that every 20 minutes for an hour. If they get better, then we can space them farther apart.
So ipratropium is going to dry them out?
It will dry them out a little bit, just so they're not drowning in their own mucus. Plus, it's a bronchodilator, okay? So you're going to give a SABA, which is your albuterol, and ipratropium in the nebulizer every 20 minutes for an hour. You with? Okay. And hopefully they're going to respond to that. But were they responding to the inhaled corticosteroids? No, because we're here. So I'm going to move it to IV corticosteroids. And we're just going to put directly into their vessels. Okay, doc? Okay. And then I gave you a little key right here because we haven't done respiratory meds yet. When did we do that, by the way? Is it a long time from now? Did we do respiratory? No, I haven't done that with y'all, right?
This is one that you need to watch out for with like certain antibiotics. Yeah. That's what you're thinking of.
Yeah. Theophylline? Yeah. Theophylline interacts with everything, and I'll tell you why in just a minute. Yeah. Well, we don't do respiratory for a long time, right? It's like towards the end. Yeah, okay. The end. All right. So I gave y'all a crash course. So if you see ICS, that's an inhaled. MDI is a meter dose inhaler. That's the regular like albuterol you may see. So when I write it on a prescription pad for a patient, I write albuterol MDI. It's a meter dose inhaler and it has to come with a spacer. Remember?
Is that a big thing?
Yeah, the long tube. Yeah. Okay. A DPI is a dry powder inhaler. So those are ones that they come in little packs that look like birth control packs. Mm-hmm. You pop out the pill, you put it in the circle inhaler, you slide this and it crushes the pill and then you put it in your mouth and you breathe in the powder. That's a DPI or a dry powdered inhaler. Ipratropium also comes that way. Okay. And you'll see us talk about that again in COPD because that's the one that they usually use. Then y'all know what a SABA is. Well, what? Short acting beta agonist. What drug is a SABA? Albuterol. Y'all, come on. You got this. Okay. We have 3 Hail Marys for status asthmaticus. So if we're giving back-to-back nebulizers, Q20 for 1 hour. Good, good. Okay. Then and they're not showing improvement, then we call that status asthmaticus. There are 3 Hail Marys that we may use to be like, we hope this will help you start breathing. If not, I am sorry. Okay. So number 1 is theophylline. We have not had respiratory drugs, but theophylline has a keyword. It is crack for the lungs. Crack for the lungs. Now, what does crack do to you when you take it? Oh, yeah. Okay, so this puts you into a major fight or flight because what does fight or flight do to your airways? Exactly. So what side effects do you think you'll see of theophylline? Okay, worse. Palpitations, really high heart rate, right? They're going to vasoconstrict, right? Because you're getting a fight or flight. So their blood pressure is going to go sky high. So what do you think you should not take with theophylline? You shouldn't drink caffeine, probably, right? So y'all need to think it is called crack for the lungs. It is a very powerful, potent drug. So that's why we consider it a Hail Mary because the side effects are so bad. Do you understand?
Yeah.
All right. Our next Hail Mary is mag sulfate. What's your keyword for mama mag? It's a mama muscle relaxer. So it's going to relax your airways and allow them to open. Okay. Have we talked about mag toxin here? Okay, I'm going to give out just a really quick crash course. I think I wrote this thinking we were already going to do respiratory meds, but y'all are just kind of starting from nothing. All right, so magnesium is considered a Hail Mary, not because it's a bad drug. It's actually a very good drug, but you can go into toxicity very easily. What do you think Mama Mag toxicity is going to look like? If it's a muscle relaxer.
Oh, CNS depression?
Right. And everything is going to relax too much, right? There's an acronym for MagTox. It's called BURP. Okay. So what do you think the B BURP? Sorry. I don't know what I was thinking. My bad. Okay. I was talking at the same time, which was just a bad idea. All right. So knowing what MAG does, what do you think the B is?
Blood pressure? Breathing?
You're actually going to describe symptoms up here is what we're seeing.
Oh,
okay. So
bradycardia.
bradycardia. Anybody want to guess at the U?
Yeah,
Yes.
we did.
Oh, okay. I was like, I thought we had done this at some point. What's the U? Well, there's not very many things that start with a U, so let's be serious. Huh? That's hard. Urine output decreased.
Good job.
Mm-hmm. What do you think the R is?
Respiratory?
Respiratory rate decreased. Did you blow out the candle?
I did, yeah.
It smells like hamburgers. And then the P. Y'all will never even guess this one. It's patellar reflexes are decreased. So when you try to do like DTRs, there's not any. Y'all know what DTRs are?
Yeah.
Okay. You like do the little, the little hammer on their leg and like ain't nothing happening because it's a muscle relaxer. You with?
Yes.
All right. Do we understand your 3 Hail Marys for status asthmaticus?
Yes.
Theophylline. Code word. Crack for the lungs. Mag sulfate is a mama. Oh, I didn't do the last one. And then the last one is racemic epi. Okay, what is epi? Epinephrine. What two things, big two things does it do? Bronchodilation and vasoconstriction, which is great for this patient. Racemic epi is where they give epinephrine in a nebulizer. Wow, that's wild. Now, obviously, it has the same side effects as epinephrine, which will give you massive fight or flight side effects. Yeah? Okay.
So this acronym is
That's signs of mag toxicity up there. Yeah. All right. Then let's talk management. Okay. The SABA PRN. What is your SABA? What drug? Albuterol. Now we got it. All right. Albuterol. That is a rescue med, right? Your ICS. What does that stand for? Inhaled corticosteroid. What drug is that? Fluticasone. That's right. Okay, it's inhaled, and it is a maintenance. What do you tell them about maintenance meds? Take it every day, whether you feel good or you don't feel good. It's meant to be done every single day. Okay? Okay. There are drugs called leukotriene modifiers. What do y'all know about leukotrienes? Oh, so okay, so they are okay, so go with that. So white blood cells come out when there's some kind of either inflammation, like something is wrong with the body, right? In this case, what do you think is wrong with the body? Allergen, right? So the allergen signals your leukotrienes to come out. So they're white blood cells that will come out in an allergic and asthma response. So there are drugs that we can give that are called leukotriene modifiers, and they end in leucast. Thank God. Like montelukast. That's singular for those of you if you've ever heard of that before. Okay. So if it ends in leucast, that leukotriene you see what I'm saying? Mm-hmm. Y'all might want to jot these down. Okay. So, and I put an M next to it because that means it's a maintenance med. This is not something I can give acutely when they're having an asthma exacerbation. It's a medicine that they're supposed to use every single day, whether they feel good or don't feel good, to tell your leukotrienes like, hey, settle down a little bit. You're bringing too much of an allergic response. Do we understand? Okay. And then the next drug class would be mast cell stabilizers. Does anybody know anything about mast cells? Okay. Mast cells are another type of white blood cell. Okay. And they also come out when there is a major allergic response. Mast cells have granules in them. So when they come out, they break open and all the little granules call cytokines. What is cytokines' job? Sound the alarm. Okay. So mast cells make a huge inflammatory response. Well, I do need a little bit of inflammation, but remember our immune system always over responds, right? Okay. So we need mast cell stabilizers, drugs that we're going to give to tell your mast cells come out, but like, let me stabilize you a little and chill you out because you're calling too much inflammation to the area. You understand? Okay. Those also have an M next to them, which means maintenance. What drug do we give for asthma that is an anticholinergic?
Antihistamines?
No. Well, that's not a bad response. Actually, that is kind of fair. You can give antihistamines because it is an allergic response, so that is a possibility. But there's one drug I gave y'all specifically that's an anticholinergic. And I said they all ended the same thing, and we're going to see it again in COPD. It dries them out. It's also a bronchodilator. You give it with a SABA every 20 minutes when they come in an exacerbation.
Oh, low dose?
No. They come in an acute exacerbation. I open the nebulizer. I put in albuterol and this drug.
Low dose?
I'm asking for the drug that you put in the nebulizer with albuterol every 20 minutes when they come in for asthma exacerbation. I'm asking again. This is the drug that you put in a nebulizer with albuterol every 20 minutes. Thank you very much. Ipratropium. You give albuterol. Y'all, I've said it like 100 times. Albuterol plus ipratropium in a neb every 20 minutes. Yes? Okay. So, ipratropium. Oh, go get, there's more in there.
We eat the rest of the bag. We eat the rest of the
What, are you only going to have one?
Yeah.
Yeah.
She's like, yeah, bring it.
We'll do it in a second.
Okay. All right. So, anticholinergic. What is your anticholinergic? Ipratropium. Very good. I know this is harder for y'all because you haven't had the farm, and I'm fully acknowledging that. Okay.
It's okay.
All right. In an acute exacerbation, what's the first thing you do?
Sit the patient
And then
up.
sit them up.
You're listening to their lungs.
Auscultate, pulse ox, and then you're going to give them,
Maybe.
what are you going to put in the nebby?
Ipratropium.
Plus albuterol. Ipratropium plus albuterol every
20 minutes.
20 minutes for an hour. What if they are unresponsive after the hour?
Hail Marys.
That is called status asthmaticus, and we're going to throw one of the 3 Hail Marys. Hail Mary number 1, theophylline. Code word, crack for the lungs. Number 2, mag sulfate. Mama mag is a mama muscle relaxer. How do you know they're in toxicity?
Oh, burp.
Burp. Okay. Number 3, Racemic epi, which is epinephrine that is given
Nebulizer.
via nebulizer. Very good. All right, obvi when they come in, we're going to start them on IV fluids because you want them drinking and eating while they're like, no. So we'll put them in PO. We put them on IV fluids. All right. You're going to set up a very calm environment so they don't get all kinds of upset. You with?
Yes.
Okay. You go and auscultate the patient. You notice there's no more wheezing anymore. Oh, no. That is called silent chest. You need to be prepared with an intubation tray because they're probably about to crack out on you. Yes, yes. Okay. Why do we not give asthma patients NSAIDs or aspirin?
10% of them have an allergic reaction.
10% of them have a cross allergy. Yes. So no NSAIDs, no aspirin. You with me? Okay. Turn your papers over. Thank you so much. All right. Your patient comes in status asthmaticus. What drugs are you going to give in the nebulizer first? Albuterol, ipratropium, every 20 minutes for an hour. Okay, good, good. You're obviously going to start ABGs, put them on an SpO2, and consider a Hail Mary if they're unresponsive. You with me? What is the number one nursing diagnosis for this patient? Ineffective airway clearance. Don't ever pick breathing pattern as number one because that ain't ever it. Because most of the time your breathing patterns are compensatory, so we wouldn't do that. It's always going to be airway clearance because they have too much mucus. We're going to put them on very high amounts of IV fluids because we need to keep the mucus thin, right? And yes, and moving is correct, okay? If your patient has exercise-induced asthma, what will you tell them to do before exercise? Use their inhaler, 2 puffs of albuterol before exercise. Okay. How do we know how well this patient's asthma is being maintained?
Yes.
All right, so they're going to do a peak flow. What do you know about a peak flow?
They need to have their baseline and they need to do them once or twice a day?
Yeah, twice is okay. Sometimes I'll ask you to do the best of 3, okay? Or you can even do it one time with the best of 3, all right? Remember, it's a little device. They have to stand up, take a big deep breath, and they blow into it, right? And then it gives you a number, and then you do that 2 more times. Whichever is your best number, that's what you jot down. And what do we use that number for?
Now you're getting better.
Or to know how well you're maintained. You've got green, yellow, and red zone. Everybody needs to get this out. All right, so we're going to fill this out based on your knowledge right now, what you have learned from this morning. Okay. All right, what is the green zone? What percentage would they need to be in? Greater than 80% of their personal best. You'll need to write that in there somewhere. This is a practice sheet, so you can write all over it. So somewhere in there, this means they're greater than 80% of their personal best. So just to make things super easy, let's say their best is 100. That would be terrible and they'd be dead. But let's just say their best, the best that they've blown is 100. Okay, that's like about where their personal best is. So what numbers would you consider the green zone for that patient? 80 to 100. So if they're blowing between 80 to 100, they're in the green zone, which means they don't have any symptoms. They're all fine. Everything looks great. So in the green zone, it says use these controller meds as listed. What's a controller med? It's a maintenance med. So which med is your maintenance med?
Short acting, long, low dose.
Inhaled corticosteroid. Yes, which is fluticasone. Very good. So you're going to use your ICS in here. That's your inhaled corticosteroid. The most common one is fluticasone. And you would do like 2 puffs twice a day. Okay. Tell me when y'all are ready to move the next one. Okay. So the yellow zone, this is from greater than 50% to less than 80%. So what number would this patient be at? 50 to 79, right?
So 80 to
Greater than 50, but less than 80. The yellow zone is when you're kind of starting to get sick. You're coming down with the colds, and pretty much if you have asthma and you get an illness, you're going to have an exacerbation, right? So in the yellow zone, they're short of breath. They may be coughing, wheezing, having a little chest tightness. Like you're not feeling good. So in the yellow zone, it says continue with the controller medicines as above, which would be fluticasone, inhaled corticosteroid, 2 puffs twice a day, and add these rescue medicines. So what do you need to put down in there? Albuterol, MDI. What does MDI stand for? Meter dose inhaler. Meter dose inhaler. And they're going to do 4 puffs every 4 hours. Q4 for at least 3 days. And then you can do as needed after that. Okay. So we're basically taking their rescue medicine and putting it around the clock because they're getting sick. Do you understand?
Mm-hmm.
All right. That's the yellow zone. What is a red zone?
Danger.
This is danger. This means you really need to go to the ER. So this would be less than 50% of your personal best, meaning you're breathing out only half of what you normally do. You're having severe breathing problems. You can't do your usual activities. You're having a hard time walking, talking, and your rescue meds ain't doing shit. Okay? So in the red zone, it says, take this medicine and call the doctor now. What do you think you take? Albuterol 6 puffs right now, and then you need to go right into the hospital. Because we realize when they go into the hospital, obviously they're going to have to wait and yada, yada. So just go ahead and take it. Okay? If the symptoms don't improve and you can't contact the doctor, go to the hospital or call 911. Just you need to be seen. Now, when I get them into the ER, what's the first thing I'm going to do for that patient? Sit them upright. Listen. Get them on a pulse ox and administer albuterol plus ipratropium in a nebulizer every 20 minutes for 1 hour. Okay. And then I'm going to keep watching them and look for any of the red flags, right? We're going to start a IV. What am I going to put in it? Fluids and? Yes, IV corticosteroids. Okay. Y'all with me? Okay. Okay. You know what I'm done. Where was I at? Okay. Do you understand how to use this? This will go, a copy of it goes in their chart, and then you send it home with the patient, several copies home. This will go, like if it's a kid, one of them needs to go to their school or their daycare or wherever they're at, and the other one needs to go in the fridge. This is what you give to the patients or the parents to let them know this is how to maintain your asthma. Do you understand? Okay. Yes.
When I was in New York,
Uh-huh.
it's in this elective class.
Mhm. Okay.
And one of the class we had to go into like middle school. I think middle school, 8 children, 6 to 8 years old.
Oh, okay.
And we had to educate them about asthma.
Oh, you did?
And
That's
we
cool.
had to like draw the plan. We had this,
Oh, so you know how to use it.
a little bit.
Yeah.
A long time ago.
Oh, okay. But still, it's familiar, which is nice.
Yeah, after that, we got certified as school facilitators.
Ooh, that's really cool. That's good. That's really good for schools. All right. Asthma action plan needs to be kept on the fridge, and they need to keep their peak flow readings and their log every single day. Yes? Always use a spacer. What do they have to do after they use their inhaler and the spacer?
Clean it. Wait, no.
Oh.
Rinse their mouth out because they can get thrush
Thrush.
inside their mouth from the inhaler. Okay.
You don't swallow it.
What? Oh no, spit it. Yeah, swish and spit. Shake the inhalers before you use them because they are dry. Either some of them are dry powder, some of them are the meter dose inhalers, but they need to be shaken, shooked. Okay. You're going to teach them to avoid their triggers. So we need to find out what the triggers are and then avoid those, obviously. They need to have a symptom journal. Write down when they have symptoms, what they were doing so we can pinpoint what they're allergic to. Yeah? Obviously, you're going to tell them not to smoke and they need to maintain a BMI less than 25 because the heavier that you are, the harder it is for you to breathe. They need to get vaccinations every year, especially flu plus pneumococcal, even if they're not an old person. Do we want them to exercise? Absolutely. We want to move those lungs. Involve caregivers and family members in the plan of care. Somebody needs to know where are your inhalers, right? Because sometimes when you get an asthma exacerbation, you can't speak. Yeah, so you need somebody that knows. And it is very important to talk to them about medication compliance. They've got to be on their maintenance meds or they're going to end up in the hospital all the time. So if you look at the bottom where it says goals for this patient, this is very important. The main goal for the patient is to have no ER required red zone admissions. So when a patient comes to me for an asthma checkup, like, hey, we're here for a follow-up or whatever, the first question I ask is, have you been in the ER at all over the last year? That is our goal, is to keep them out of that. Number 2, we want them to be at greater than 80% on their personal best peak flow readings. Does that make sense? And then the one at the bottom says symptoms less than 2 times per week. That is our goal, right? Because that is mild intermittent asthma. And if you're going to have asthma, that's the best one to have because it's step 1. Do we understand? All right. How do we feel about asthma? That was a big one.